Hello everyone, my name is Kyori Kim, and I'm one of the social media section editors of the Archives of Plastic Surgery. I'm excited to introduce Hot of the Press. Twice a month, we'll be hosting Hot of the Press with one of the authors of latest APS paper and two panelists. It offers you a special opportunity to directly hear from the authors and join an insightful discussion between panelists. You can also leave your thoughts as a comment for further discussion.
Hi, everyone. Welcome back to Hot of the Press. This is for September issue. Today, we're joined by Dr. JJ Huang and Dr. Chun-Lin Su from Chang'an Memorial Hospital at Taiwan. Today, they will discuss their article, Direct-to-implant breast reconstruction following nipple-sparing mastectomy, predictive factors of adverse surgical outcomes in Asian patients. So we'll be joined by Dr. Su presenting his presentation.
We're so happy to be invited to share our experience in direct-to-implant. And first of all, I'd like to give a short briefing of our study. Nipple-sparing mastectomy has gained a lot of popularity over the past decades. And comparing to skin-sparing mastectomy, it has compatible oncological outcomes and much better quality of life. However, this procedure was more technically challenging because of the higher complication rate, considering the nipple areolar complex perfusion. And immediate implant-based reconstruction could be performed by one or two stage. And comparing the one-stage direct implant and two-stage tissue expander, both procedure has good oncological and aesthetic outcomes. However, the superiority remains inconclusive and conflicting. And currently, the procedure has been largely shifted to direct implant, especially in the nipple-sparing mastectomy. The ADM is a biomaterial used in breast surgery, serving as a low lateral sling for the implant coverage. And it also improves the aesthetic outcomes by better IMF control and less capsular contracture. However, it has a higher complication rates such as seroma, infection, and skin necrosis. But this material has been widely used in other countries in implant-based reconstruction. And in Chang'an, since early 2000s, we have performed a lot of direct-to-implant in either nipple-sparing or skin-sparing mastectomy. And even though that we never use the ADM, we still have acceptable aesthetic outcomes in our smaller breasts in Asian females. And the previous literatures regarding this combined procedure mostly stick to the use of ADM and include the prophylactic mastectomy. So this study was aimed to review our experience of the nipple-sparing mastectomy and direct-to-implant without the use of ADM and evaluate a suitable candidate for this procedure. And it's a retrospective cohort from 2009 to 2020 in a single institution in Ningkou, Chang'an. And surgery was performed by a single surgeon. And our surgical technique, we will take over for reconstruction after the breast surgeon finished mastectomy. And first we will check the perfusion of the nipple areolar complex and the skin flap. Sometimes we will use the ICG and SPY device. And if the skin perfusion was compromised, we might convert to the tissue expander. And then we did the subpectoral plane dissection and division of PM muscle insertion below force in the costal level for better breast shape. And after the implant placement, we did the anchoring suture over the IMF and the anterior axial line to create the lateral fold. And these are our parameters, and our outcomes include 4 aspects, including acute and late complications, implant and expander removal, and the revision of static surgery. And the first part, we'll compare the 2 procedures. And the second part, we'll use the regression model to assess the risks of adverse surgical outcomes in direct-to-implant reconstruction. So the first part is the table one is the demography between the two procedures. We found that the direct-to-implant has elder age and lower BMI. And the table two was the tumor characteristic and associated treatment. And we found that the PMRT was more frequent in the tissue expander group. And table three was the intra-op data and post-op outcomes between the two procedures. We found that the tissue expander group had larger mastectomy and the implant size, and also the borderline higher rate of the skin flap necrosis. Besides, the tissue expander group had higher rates of the exposure rate and borderline higher rates of the failure. And the next step, we'll use the regression model to assess the risk in the direct-to-implant. And first, the two outcomes was acute and late complications. We found that the advanced age increased the risk of acute complications. And also the larger mastectomy size increased the risk of acute complications. And the next was the implant removal and revision of aesthetic surgery. And we found that the IORT on the nipple areolar complex increased the need of revision of aesthetic surgery. And then finally, we use the multivariable model to assess the risk. And in summary, the advanced age, IORT, and mastectomy size had higher risks of adverse outcomes. So, and I show two cases. This is a right nipple-sparing mastectomy plus the direct-to-implant. And the second case was the left nipple-sparing mastectomy and direct-to-implant plus contralateral augmentation. So comparing the direct-to-implant and tissue expander, the direct-implant was more preferred over tissue expander since 2010 when the ADM was introduced. However, the outcome was still conflicting in the previous literatures. And our studies without the ADM favor direct-to-implant with less complication rate and failure rate. However, our study might have possible selection bias in our study because we tend to perform tissue expander if the PMRT was required and the perfusion of the skin envelope was compromised. And the mastectomy size and advanced age was a risk for the acute complication, and they will also be reported in some study previously. And these two factors indicates a ptotic, might indicate a ptotic breast, which has longer travel distance of collateral circulation to the wound edge, and might be have a restrict perfusion of the breast envelope, and then lead to the skin complications. And IORT was a risk for both a revision of aesthetic surgery and acute complications. The IORT on the nipple areolar complex we use as a reinforced radiation during the surgery to decrease the local nipple recurrence. And our revision surgery includes a scar and nipple revision. The explanation of IORT might be that it will damage the perfusion of the nipple areolar complex and then lead to the nipple and the skin complications. The ADM assist direct-to-implant reconstruction was widely used in other countries, featuring the cosmetic benefit. However, the ADM increased the medical cost of the patient and may have more inevitable complications. There's a study discussed about their indication for ADM, including direct-to-implant and nipple-sparing mastectomy. And they also mentioned that larger breast was one of the important indication for ADM. However, in our series, our patient was mostly had small and non-ptosis breast. And we also did an anchoring suture on IMF. And that might be why we could have acceptable outcomes, even though we didn't use the ADM. And there are also some limitations in our studies. So in summary, in this combined procedure without ADM, it's a feasible procedures in Asian patients with smaller breasts and the larger breast size, advanced age, and IORT on nipple area complex might increase the rate of adverse outcomes. Thank you.
Thank you. Congratulations on your great study, and thank you very much for joining us on this Hot of the Press. I have a few questions. So I'm based at US. I practice at Ohio State University, and most of my patients, the BMI of 21 is very rare. And I was wondering, you say small non-ptotic breast, so what is the cup breast size that you would say you're a candidate for direct implant? And then if you ever see someone who's C or D or triple D cup bra, and what do you do for those patients?
In Asia, most of patients are like cup B and cup C. So for most of our patients, the mastectomy width are like within 450. So that's why 80-90% of the patients, especially nipple-sparing mastectomy, we can go for direct-to-implant. And because of the implant size, we don't have so many like implant lower riding incidence, and that's why we can do it without ADM. But for patients who have the grade 2 ptosis or advanced age with very thin skin, or might need to consider about convert to two-stage breast reconstruction. The BMI is not a definitive factors that we consider direct to implant or two-stage reconstruction, but instead the mastectomy quality and the original shape would be our guidance nowadays.
I see. And then when you choose the direct to implant, how do you pre-optimally predict the size that you're going to need? And do you use any like computer imaging to detect, or how do you plan for it?
Pre-operative counseling with the patients. Before this paper publication, we didn't use any computer assistance accessory. So we basically just do physical examination and explain the risk or the possibility of 1 versus 2 stage to the patients. We are lucky because in Taiwan, not so many females are smokers. So the risk from smoking is not very high here in Taiwan. So usually if the patient have like cup B and cup C, I usually tell them that our direct to implant incidence is very high. But I just give them the idea that if the skin perfusion is not good after mastectomy, I have to convert it to two-stage reconstruction. But even patients with cup D, it's still possible for us to do direct-to-implant reconstruction if the breast is not very ptotic. But that's something, that's the risk factors that we will explain to the patient and make decision at the final. But regarding to the implant size, I usually measure the patient's breast width and breast projection in clinic, and then sort of have some idea in my mind about which profile and roughly the size of the implant I need to prepare for them. Also, we would discuss about the possibility of contralateral breast augmentation or reduction if required. I don't do contralateral musclepexy that much because in Asia, people don't like the scar. So usually augmentation or reduction. But if the patient needs contralateral breast reduction, my rate of direct to implant is much lower because of the scar and concerning about perfusion of the nipple areolar complex. And nowadays, many of the mastectomies are done in a minimal invasive way, like endoscopic assistance or robotic assistance. With that, the incision is much smaller, but control of the skin envelope thickness is much better. So we can do more and more direct to implant without compromise of perfusion of the skin envelope and the preserved nipple areolar complex.
Notice the incision on the photographs are very small, and it's
getting smaller and smaller.
Yeah.
Both of the cases are traditional, but we are doing more and more MIS right now.
Right. And then one of the controversies of using the kind of subpectoral plane is like animation deformity. And That's another reason that the champions of using ADM is that you prevent that with using ADM. And what are your experience with animation deformity? How are the patients talk about it? Or
yeah, we do have patients with animation deformity, but it's not, the incidence is not very high. It's maybe roughly 3-4% only. I think the most important thing is make sure to divide that's the origin actually, the origin of the PM muscle below the fourth intercostal space. And sometimes we need to do anchoring suture of the PM muscle on top of the mastectomy skin to prevent muscle retraction and provide more perfusion on the nipple alveolar complex. But with that procedure, I only do very loose suture just to prevent further creation of the origin on the muscle, and that might cause animation deformity. In Tonga, we don't use ADM that much because of the medical cost issue and also patient's preference, of course. So we don't do so many prepectoral direct-to-implant reconstruction. The only situation that I do prepectoral is very severe animation deformity, but it's not that much. And if that happened, I mean, animation deformity happens, I would first release the muscle and put the implant back into the same bucket to see what would happen. And if that's helpful, we can prevent doing prepectoral, because for doing prepectoral, the skin coverage will be very thin, and we definitely need ADM to do that.
And how do you control the postoperative nipple position? Some doctors would put like anchor suture to the nipple and stitch it to the pectoralis, or what are your tips for those?
I don't do many suture to control the nipple position, but I do 1 or 2 ankle stitch on the pectoralis muscle, but not, the purpose wasn't for the nipple purpose. It's more like perfusion issue. But I think here in Taiwan, the patient's breast size is relatively smaller, so I think control of the nipple position is not very difficult. But I think the most challenging part is the longevity of the location of the nipple. And that's partly affected by the incision placement, because with time and scar congestion issue, if the scar is placed above the nipple level, there is a higher rate of nipple higher writing with time. So now, if possible, I would suggest my breast surgeon to put the incision placement below the nipple level, for example, the inframammary fold. And if they want to go to the lateral, which is also a very good incision placement, the anterior exterior line, I would suggest them to put it just a vertical line instead of upper oblique one. That helps a lot in terms of keeping the nipple in the right position and prevent upwriting of the nipple.
Yeah, the photos are really beautiful, and they almost look like they just got a breast augmentation.
Yeah, but if you notice that both of them have the scar, one is in the lateral, the other one in the IM. So that's good scar location.
It's always very challenging. A lot of patients, we rarely see like A or B cup bra. In my practice, a lot of them are like D, triple D. So I actually have to do like a splice pattern to reach their skin envelope most times. And then even like sometimes you try to do direct to implant, and then just because their breast has been, grade 3 ptosis for a while, so it's not kind of like challenging to do those. So I know you mentioned that you use SPY. How much % of time you would say? A lot of times also surgeon dependent as well. So what's your protocol to assess? Do you just assess with the bleeding first and go to the SPY, or do you do SPY right away?
I do SPY right away, and I do SPY right away without and with mammary sizer. So without mammary sizer, we know the baseline perfusion. Well, if it's already like very poorly perfused, I won't do the sizer part. I will just give up direct to implant. But if it looks good, then I will put mammary sizer and pump up my desired size. But the mammary size, I would just put it under the skin, just a mastectomy envelope, and then check the perfusion again. If it looks good, that means that the skin flap and the nipple areola complex is well perfused even under tension. With that, I will go direct to implant. And if it's compromised after the sizer pump up, I will go to tissue expander as well.
And for tissue expander, what kind of protocol for tissue expander? When do you start expanding, and then when do you have them come back for second stage?
Yeah, I usually, if the wound healing is no problem, I start to inflate it usually 2 weeks after surgery. And then depends on the patient's preference. We can do it weekly or every other weeks. Usually I do around 50 to 100% infusion per time, depending on the tension and patient's comfortable. So if we can do like 100, that we can reduce the time of inflation, and patient might have the opportunity to convert to permanent implant earlier if they don't need chemotherapy.
And then if they need radiation to expand, or, you know, some institute actually deflates the expander and let them go through the radiation and then come back and re-expand. What is your protocol for radiation?
If the patient needs radiation, I will expand it like what we used to do. We expand it like more than enough. And then before planning of the radiotherapy, I will withdraw a little of the cell line together with my radiation oncologist. So they actually want something there instead of just go completely flat, but they don't want it too full. So I usually withdraw the cell line with my radiation oncologist, and I'll just stop when she says yes. And then after radiotherapy, we start to inflation roughly about 1 month after the radiotherapy.
Do you ever fill with air?
And we don't have the air one in Taiwan at this moment. Yeah, I'll be very happy to try though.
I think it's like a lot of practice, or some are filling with air and then replace with saline later, or use the air expander as well. So quite interesting to see how different countries do different things. And it's really nice to see kind of like, it's hard to see like a one single surgeon experience over a period of 10 years to see that. And then I think it's a great study because it shows that what are the kind of risk factors for direct to implant. And I think because one of those, you know, kind of trend is to kind of provide aesthetic appearance breast after breast reconstruction. And then a lot of patients are asking for that direct to implant these days. So I think it's nice to know the risk factors for them, so that you could, those who are listening and then those who read your paper could discuss with the patients preoperatively, these are the risk factors for direct to implant, and that you have some certain risk factors. So you could discuss with the patient why it won't be an optimal result for them. So I think it's a great study. And thank you very much for answering all those questions. And then thank you very much for Dr. Su for a great presentation. I really love the PowerPoint.
Yeah, I'm just interested in the rate of direct to implant in US.
I think it depends. I just finished my fellowship at MD Anderson's, and I'm now at Ohio State. So far as the direct to implant, I think it varies on the institution, and also whether that institution has microsurgeon available. A lot of trend is to do implant-based reconstruction in a lot of parts of the US. And then if they have a microsurgeon, then the rate of implant-based reconstruction is actually lower than the average institution, and it's autologous-based reconstruction is a little bit higher. So I think it kind of depends on the institute, and then I would say more private would do direct to implant if they have technology and then a surgeon's available.
Yeah, I also noticed the trend in Taiwan because mine is about 50-50, like 50% reflap, 50% implant. Some of the centers in Taiwan, same, they do a lot of implant, and but some of them do direct to implant. Some of them are still like 2-stage for every single one. Yeah.
Right. So I think it's kind of like those who are adopting a new trend, and then those who are also has capacity to provide the autologous based reconstruction. So I think it varies from even like certain areas have different referral base available as well. So sometimes the implant-based reconstruction will be referred to like the private plastic surgeons, and then the academic centers will see more patients who are a little bit more complicated. So they will need higher rate of adjuvant chemotherapy or radiation. And then with that, they wouldn't be such a good candidate for direct-to-implant. So I think that's it. Thank you very much for an amazing discussion. Thank you, Dr. Huang and Dr. Su from Chenggang. And then thank you everyone for joining for this Hot of the Press. Thank you.
Thank you very much for joining this fantastic discussion. Be sure to tune in for other articles we'll be discussing on future Hot of the Press. You can also connect to the Global Plastic Surgery Society through our YouTube channel, Facebook, Instagram, and Twitter. We are looking forward to meeting you on our APS social media. Let's be social, but distant.